Carolyn Lam, Mariana Adamo, and Ovidio Chonsel, and our panelists, Johan Barsaks and Fayaz Zanad. Before we start, we'd like to acknowledge the task force members who've worked on the guidelines. And in particular, Mark and I would like to especially thank Mariana Adamo and Roy Gardner, who served as the coordinators on the guideline. Before we start, I'd also like to remind you of the classes of recommendation that we've used in this and indeed all ESC guidelines. So class 1 is a treatment which is recommended. Class 2 either is at 2A is a treatment which should be considered, and class 2B, a treatment which may be considered, and class 3, a treatment which is not recommended. And also of the levels of evidence we use in terms of assigning the weight of evidence. So class A is data from multiple randomized controlled trials and or meta-analyses. Class 2, a single randomized controlled trial or large registry data. And class C, evidence from expert opinion. So without further ado, I'm going to hand over to Professor Gardner, who's going to start off by talking about the new recommendations for the treatment of heart failure with reduced ejection fraction. Roy.
Good afternoon. I would like to thank the chairs, Teresa McDonough and Marco Metro, who've worked tirelessly over the last 2 years on these guidelines, as well as the ESC for inviting me to present these key changes in the HFrEF section of the 2021 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure. But we will start with something that hasn't changed, the definition of heart failure with reduced ejection fraction. This requires symptoms and signs, an ejection fraction of 40% or less. Later on in this session, you'll hear from Carolyn Lam, who will talk about mildly reduced and preserved ejection fraction heart failure. Now, we're fortunate to have a number of therapies that have been proven to improve outcomes for our patients. For the last 5 years, many of us have been using the therapeutic algorithm of the 2016 guidelines, almost the sequential approach starting with ACE inhibitor and beta blocker. And if patients remain symptomatic with a severely impaired heart, they get an MRA. And again, if they remain symptomatic with a severely impaired heart, steps are then made to swap an ACE inhibitor for an ARNI, consider device therapy, or class 2 recommended therapies for heart failure. You've already had a sneaky peek of the 2021 HFrEF therapeutic algorithm, but here it is in all of its glory. Now, given the importance of these key HFrEF therapies, some of which have been shown to improve outcomes within a month of initiation, we now recommend that an ACE or an ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor such as dapagliflozin or empagliflozin are commenced and up-titrated as quickly and as safely as possible, whilst using the lowest effective dose of a loop diuretic to relieve congestion. Now, we know that cardiac function can improve and the risk of death falls with the use of these key drugs, and therefore we should normally wait at least 3 months before considering device therapy. For those in sinus rhythm at that stage with an ejection fraction of 35% or less and a QRS duration of greater than 130 milliseconds, consideration should be given for CRT. In an appropriate selected patients with a QRS of less than 130 milliseconds, and where it's appropriate to do so, an ICD could be an option. And of course, we also have a number of other treatment options that can be considered for those patients who remain symptomatic despite our best efforts. Let us consider the recommendation for each of these therapies in a bit more detail. Now, of course, the recommendation for ACE inhibitors, beta blockers, MRA, and sacubitril valsartan has not changed because there's not been any improvement in the data that we have for these agents in heart failure over the last 5 years. But what is new is data on the SGLT2 inhibitors, dapagliflozin or empagliflozin, coming from DAPA-HF and EMPEROR-reduced, which saw a reduction in their primary endpoints that included cardiovascular death or heart failure hospitalization. And for this reason, the SGLT2 inhibitors dapagliflozin or empagliflozin get a Class 1A recommendation in the 2021 guidelines. As I mentioned, diuretics are still recommended to treat congestion. However, the place of ARBs is now reserved only for those who are truly intolerant of an ACE inhibitor or an ARMA. The place of ivabradine has not changed and should be considered for those in sinus rhythm with a heart rate above 70 beats per minute, despite optimally or maximally tolerated doses of beta blocker, or where the beta blocker is not tolerated or in the rare event it's contraindicated. Something else new is vericiguat, a soluble guanylate cyclase receptor stimulator, which showed a relatively modest 10% reduction in cardiovascular mortality and heart failure hospitalisation in the Victoria study. And at the time of writing the guideline, it was not licensed in Europe, and as such, clinical experience was not extensive. As such, vericiguat may be considered in those with worsening heart failure, despite the other treatments listed here. The indication for hydralazine and isosorbide dinitrate, as well as digoxin, have not changed. What is new in the 2021 heart failure guidelines is this new personalised approach to heart failure care, tailoring therapy to the phenotype of the patient. Now, as I've mentioned, it's really important to establish people on the key disease-modifying therapies for heart failure, namely an ACE inhibitor or ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor. But in selected patients, we can consider device therapy or treatments directed towards comorbidities. Now, I will discuss device therapy very shortly, and Marianne Adamo will discuss comorbidities later on in this session. In selected individuals who have advanced heart failure, there are treatment options such as cardiac transplantation or mechanical circulatory support, and a video will discuss these at the end of the session. And finally, we shouldn't forget quality of life and the role of cardiac rehabilitation. And so exercise rehabilitation and multi-professional disease management are recommended for patients with heart failure and reduced ejection fraction. Moving on to device therapy, an ICD is still recommended for secondary prevention of individuals who've had a ventricular arrhythmia causing hemodynamic instability, particularly in those who are expected to survive for more than a year with good functional status, and then in the absence of a reversible cause, and that is a Class 1A recommendation. In terms of primary prevention, in those with heart failure of an ischemic etiology, with an ejection fraction of 35% or less, despite, as I mentioned before, at least 3 months of optimal medical therapy, and again ensuring these individuals have a reasonable expectation of having a good quality of life for as long a period as possible, then an ICD in this circumstance gets a 1A recommendation. What has changed is ICD therapy for those individuals who have a non-ischemic etiology to their heart failure. And this was previously a Class 1 recommendation. And in light of the data from the Danish study, this is now a 2A or should consider recommendation, again in those individuals who have a severely impaired heart, despite optimal medical therapy for at least 3 months. Where ICDs are not recommended are in instances within 40 days of a myocardial infarction for primary prevention, as this does not improve prognosis, but also in individuals who have refractory NYHA Class 4 symptoms, unless, of course, they have an exit strategy, such as listing for cardiac transplantation. And finally, we move on to CRT. This is an excellent therapy for the right patients. And these indications are for those individuals who are in sinus rhythm with an ejection fraction of 35% or less, despite optimal medical therapy. And the greatest weight of recommendation is to those individuals with a wide left bundle branch block, greater than or equal to 150 milliseconds. And this gets a Class 1A recommendation. What is less certain is those individuals with more modestly prolonged QRS, left bundle branch block morphology, or those individuals with a wide non-left bundle branch block morphology, and they get a 2A recommendation with a level of evidence B, or should consider. The group of individuals we know least about are those individuals with a non-left bundle branch block morphology with a QRS duration of between 130 and 149 milliseconds. and they get a to be or may consider classification. Think about other recommendations for CRT. There's a class 1 recommendation for individuals who have high degree AV block with severe left ventricular systolic dysfunction. CRT is indicated rather than RV pacing to reduce morbidity. And this, for the first time, includes patients with atrial fibrillation. As I mentioned to you, the previous indications for CRT were in individuals who were in sinus rhythm. We are not giving other recommendations for individuals with atrial fibrillation because of the paucity of data. In individuals who have a conventional pacemaker and a worsening heart failure despite optimal medical therapy, and they have a significant proportion of RV pacing, these individuals should be considered for a so-called upgrade to CRT. And these recommendations are all aligned to the pacing guidelines, which are also being presented at this meeting. And again, CRT is not recommended in patients who have a narrow QRS, a QRS of less than 130 milliseconds, who do not have high degree AV block. And this is consistent with Frank Wyszycka's ECHO CRT study. And so in summary, here are the key changes to the HFrEF section of the 2021 heart failure guidelines. There's now a new class 1 recommendation for the SGLT2 inhibitors, dapagliflozin and empagliflozin. We now recommend that the 4 key drug therapies, ACE inhibitor or ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor, are initiated as quickly and as safely as possible. We're emphasizing the importance of tailored management, personalized medicine. And from a device perspective, primary prevention ICDs and non-ischemic cardiomyopathy is now a 2A recommendation, having previously been a 1. And of course, there's emphasis on the broadest QRSs, particularly in left bundle branch block, in selecting patients for CRT. And so in summary, I would like to leave you with the new 2021 heart failure treatment algorithm for reduced ejection fraction heart failure. Many thanks for your attention.
Thank you very much, Roy, for that very clear presentation and pointing out the main changes in the HFrEF section of the guideline. So I'm now going to turn to Caroline Lamb, who's going to talk us through the diagnosis and treatment of HFmrEF and HFpEF. Caroline.
It is my privilege to present the classification of heart failure and the diagnosis and treatment of heart failure with mildly reduced and preserved ejection fraction on behalf of the 2021 ESC Guidelines Task Force. Here are my disclosures. The guidelines emphasize that heart failure is a clinical syndrome consisting of cardinal symptoms that may be accompanied by signs. It is due to a structural and/or functional abnormality of the heart that results in elevated intracardiac pressures and/or inadequate cardiac output. Thus, the heart failure diagnostic algorithm begins with the clinical assessment of symptoms and signs, and also stresses the importance of the B-type natriuretic peptides and echocardiography to determine the underlying cardiac abnormality responsible for the symptoms. Only after the diagnosis of heart failure is confirmed, the guidelines recommend classification by left ventricular ejection fraction into those with a reduced ejection fraction, that is of 40% or less, those with a mildly reduced ejection fraction, above 40% but less than 50%, and those with a preserved ejection fraction of 50% or more. Importantly, for all forms, the presence of the clinical syndrome of heart failure is a prerequisite. Now, there are key changes from the 2016 guidelines. There's a change of the term from heart failure with mid-range ejection fraction to heart failure with mildly reduced ejection fraction, thus keeping the acronym, but introducing the term reduced based on evidence that these patients may benefit from similar therapies to those with heart failure and a more severely reduced ejection fraction. For the diagnosis of heart failure with mildly reduced ejection fraction, elevated natriuretic peptides and other evidence of structural heart disease make the diagnosis more likely but are not mandatory if there is certainty regarding the measurement of ejection fraction. Furthermore, there is a new table of recommendations for the treatment specifically of heart failure with mildly reduced ejection fraction, a marked change from the prior guidelines, which lumped mid-range and preserved ejection fraction in the treatment recommendations. And here is that new table. As for all forms of heart failure, diuretics are key in the management of congestion. However, since there have been no substantial prospective randomized controlled trials really exclusively done in heart failure with mildly reduced ejection fraction, no other strong recommendations can be made. The guidelines, though, based on post hoc analysis of subgroups of trials that have included this ejection fraction range, have suggested therapies that may be considered in these patients, especially because many of these patients are already on these therapies for other cardiovascular indications like hypertension or coronary artery disease. And the therapies are ACE inhibitors, ARBs, beta blockers, MRAs, and ARNI. In other words, similar to those for HFrEF. Now moving to HFpEF. The guidelines acknowledge the historical changes in nomenclature and the lack of consensus on the optimal ejection fraction cutoff to define this group of heart failure without overtly reduced ejection fraction. For instance, in the CHARM-PRESERVE trial, the term was used to refer to all patients above a 40% ejection fraction. And so there is debate regarding what constitutes mildly reduced ejection fraction, the specific cutoffs, and whether this should be different for women versus men. The guidelines also questioned whether heart failure with a higher ejection fraction should be named heart failure with normal ejection fraction. However, given the known variability of measurements of ejection fraction and remaining controversies regarding the precise cutoffs to define normal, this guideline has kept to the nomenclature of heart failure with preserved ejection fraction using a cutoff of 50%. Still, clinicians must be aware that ejection fraction is a continuous variable with a normal distribution in the general population, and thus cutoffs used in definitions are necessarily arbitrary. Also, if there is heart failure with a very high ejection fraction above 65 or 70%, this should prompt a search for pathology such as amyloidosis or hypertrophic cardiomyopathy, where left ventricular end diastolic volume may shrink, and thus there's a small denominator for ejection fraction and supranormal ejection fraction. The guidelines also acknowledge that the diagnosis of HFpEF remains challenging. Numerous criteria have been proposed in clinical trials and by societies with varying specificities and sensitivities. Furthermore, not all clinicians will have access to specialized tools that have been recommended in some criteria. Thus, to facilitate broad clinical application, this guideline recommends a simplified, pragmatic approach that distills the common major elements in prior criteria and emphasizes the most frequently used variables widely available to clinicians. The recommendation is consistent with the consensus document of the Heart Failure Association and does not represent a new algorithm or diagnostic score, but rather a simplified approach. And physicians with access to expertise may refer to the full HFA recommendation. This simplified diagnostic approach starts with the assessment of pre-test probability and should include the three criteria of symptoms and signs of heart failure, ejection fraction above or equal to 50%, and objective evidence of cardiac structural and functional abnormalities consistent with the presence of left ventricular diastolic dysfunction or raised left ventricular filling pressures. Now, for the second criterion of ejection fraction, it's important to note that patients with a history of overtly reduced ejection fraction who later present with an ejection fraction above 50% should be considered to have recovered or improved ejection fraction rather than HFpEF. and continued treatment for HFrEF is recommended in such cases. Now, for the third criterion of objective evidence, there is a simplified table provided to aid the diagnosis of HFpEF, and these include commonly used parameters like left ventricular mass index, relative wall index, relative wall thickness, left atrial volume, mitral E to E prime, natriuretic peptides, pulmonary artery systolic pressures, and their respective cutoffs. Importantly, the guideline advocates for a probabilistic approach where the greater number of abnormalities present, the higher the likelihood of HFpEF. And finally, for the treatment of HFpEF, the guidelines acknowledge that at the time of publication, no treatment has been shown to convincingly reduce mortality or morbidity in patients with HFpEF, although improvements have been seen for specific phenotypes within the overall umbrella. The task force also acknowledges that the treatment options for HFpEF are being revised even as the guideline is being published. For example, the FDA has approved the use of sacubitril/valsartan in adults with chronic heart failure, particularly when ejection fraction is less than normal. And in this very Congress, we will hear late-breaking results from other significant HFpEF trials. For now, the recommendations for treatment of HFpEF have remained largely unchanged. It is important to screen for and treat etiologies and comorbidities. In the absence of disease-modifying therapies, diuretics are recommended for the management of congestion. And in text, it is also mentioned that reducing body weight in obese patients and increasing exercise may further improve symptoms and exercise capacity and should therefore be considered in appropriate patients. Thank you.
Thank you very much, Carolyn, for that very good summary of the HEF mildly reduced and HFpEF sections. I'm now going to hand over to Marco to introduce the next speakers.
Thank you, Teresa. We know heart failure is an heterogeneous disease. We have moved from HFrEF to FMREF and HFpEF. And now it's my pleasure to introduce Professor Dr. Mariana Adamo, who will deal with the new recommendations for comorbidities and special conditions. Thank you.
Hello, everyone. And thanks to the EAC and to the chairman for giving me the privilege to present these guidelines. I will focus on cardiovascular and non-cardiovascular comorbidities and on special conditions associated with heart failure. Let's start immediately with atrial fibrillation. And here we have a new algorithm for the management of patients with atrial fibrillation and HFrEF. Anticoagulation for stroke prevention, treatment of possible triggers, and optimization of heart failure therapies are recommended in all patients. And then, if the patient is unstable, an electrical cardioversion is recommended, and if the sinus rhythm is restored, a pulmonary vein ablation should be performed to prevent possible recurrence. Or, in alternative, amiodarone may be administered. If the patient is stable, a rate control strategy, including beta blockers, digoxin, or intravenous amiodarone, should be adopted, and if there is a persistence of symptoms, a pulmonary vein ablation should be considered for treating atrial fibrillation, or as an alternative, amiodarone or electrical cardioversion may be done. Finally, AV node ablation may be considered only if the rate and rhythm control strategies fail. Chronic coronary syndrome is another important comorbidity in heart failure, and these are the new recommendations for myocardial revascularization in HFrEF. Coronary revascularization should be considered to relieve persistent symptom of angina or equivalent despite optimal medical therapy. Moreover, it may be considered to improve outcomes after a careful evaluation of the individual risk-to-benefit ratio, including coronary anatomy, comorbidities, life expectancy, and patient's perspective. CABG should be considered as the first choice strategy, especially if the patient has diabetes or multivessel disease, whereas PCI may be considered as an alternative to CABG based on the heart team evaluation. In these new guidelines, you will find indications for valvular heart disease in heart failure, including aortic valve disease and also tricuspid regurgitation. Today, we will focus on secondary mitral regurgitation in FRF patients because here we have the major changes. And this is a new algorithm for the management of this patient, whereas you can see the role of the heart team is crucial and two aspects need to be considered. The first is the need for coronary revascularization, and the second is the optimal medical therapy, including CRT if indicated, which is mandatory before considering a patient for possible mitral valve interventions. So if the patient needs for coronary revascularization, a PCI may be considered only if the surgical risk is high and the patient must be re-evaluated for symptoms and mitral regurgitation degree. Otherwise, a CABG with a mitral valve surgery should be performed. If the patient doesn't need coronary revascularization and there is a persistence of symptoms and significant mitral regurgitation despite optimal medical therapy, the patient must be re-evaluated by the heart team, and if the surgical risk is low, surgery may be considered. Otherwise, we have to look at the COAPT criteria, and if these criteria are fulfilled, a percutaneous age-to-age mitral valve repair should be performed to improve outcomes. If these criteria are not fulfilled, a percutaneous age-to-age mitral valve repair may be considered to improve symptoms or as a bridge to transplantation or bridge to LVAD. We also have some new important recommendations for non-cardiovascular comorbidities. Regarding diabetes, according to the main recent clinical trials on diabetic patients, SGLT2 inhibitors are recommended in patients at a risk of cardiovascular events in order to reduce heart failure hospitalization, cardiovascular events including death, and end-stage renal dysfunction. Moreover, based on the recent trials in heart failure patients, DAPA-HF, EMPEROR-Reduce, and the Soloist WHF trials, dapagliflozin, empagliflozin, and sotagliflozin are recommended in patients with type 2 diabetes and FRF to reduce the risk of heart failure, hospitalization, and cardiovascular mortality. Iron deficiency is another common comorbidity in heart failure. Therefore, all patients with heart failure must be periodically screened for anemia and iron deficiency. Moreover, in addition to the well-known indication for ferric carboxymaltose in outpatients with iron deficiency for symptoms and quality of life improvement, we now have a new indication in these patients based on the results of the AFFIRM-AHF trial, so ferric carboxymaltose should be considered in symptomatic patients recently hospitalized for heart failure with an ejection fraction less than 50% and iron deficiency to reduce the risk of a heart failure or hospitalization. Regarding cancer, a cardiovascular risk assessment is recommended in cancer patients at increased risk for cardiotoxicity, but it should also be considered in all patients who will receive a potential cardiotoxic cancer treatment. Regarding heart failure treatment in these patients, an ACE inhibitor and a beta blocker should be considered in cancer patients with a new onset of left ventricular dysfunction before scheduled anti-cancer therapy. Finally, we have new indications for special conditions. In these new guidelines, you will find a new algorithm for pregnant patients with heart failure and the new tables for the management of cardiomyopathies. Today, we will focus on myocarditis and amyloidosis. This is a new algorithm for the management of patients with suspected myocarditis without colors for recommendations, as you can see, because we don't have specific randomized trials in this setting. However, we have a specific diagnostic workup, including cardiac magnetic resonance. And coronary artery disease must be obviously excluded. Heart failure treatment must be given. And if there is a clinical stabilization, heart failure treatments must be maintained. Otherwise, mechanical supports can be considered. An endomyocardial biopsy is indicated if there is a persistence of hemodynamic instability or if specific etiologies such as autoimmunity or infectious are highly suspected. Finally, we have a new algorithm for the management of patients with suspected cardiac amyloidosis. In these patients, both hematological tests and bone scintigraphy need to be performed. And if they are both abnormal, as in rare cases, a cardiac biopsy needs to be performed in order to identify the amyloidosis subtype, AL or transthyretin. A cardiac or extracardiac biopsy is indicated also to confirm the diagnosis of AL amyloidosis if we have an abnormal hematology with a normal bone scintigraphy and a positive cardiac magnetic resonance, or to confirm the diagnosis of transthyretin amyloidosis if we have a normal hematology with a low uptake at the bone scintigraphy. If we have a normal hematology with an intermediate to high uptake at the bone scintigraphy, the diagnosis of TTR amyloidosis is done and the genetic counseling is needed in order to identify genetic form. In these patients, in patients with transthyretin amyloidosis, we now have new indications for treatment based on the AT-TRACK trial. Indeed, tafamidis is recommended in both patients with hereditary and wild-type transthyretin amyloidosis, near class 1 or 2, in order to reduce symptoms, cardiovascular hospitalization, and mortality. Thank you for your attention.
Thank you, and it's now my pleasure to introduce Professor Ovidio Quincel, who will deal with advanced and acute heart failure. Ovidio.
I'm Ovidio Quincel from Bucharest, Romania, and I will use this opportunity to thank AAC and the chairman of the guidelines inviting me to present advanced and acute heart failure. This is my disclosure. And I will start with advanced heart failure. And I think that the new guidelines give a special attention to advanced heart failure, distinct to previous guidelines where several terms have been used, like end-stage refractory terminal. Now, the current guidelines harmonize the concepts and provides a new definition. And actually, advanced heart failure is recognized as a distinct clinical entity in the progression of heart failure. It corresponds to stage D from universal classification, and Intermax profiles has been used to classify this type of patients. HFA position statement on advanced heart failure has been incorporated in the new guidelines for the definition, and all 4 following criteria must be present. And first, it's severe and persistent symptoms despite optimal medical therapy, severe cardiac dysfunction regardless of level of ejection fraction or type of cardiac involvement, left or right, and episodes of congestion or hyperperfusion requiring at least 1 episode of outpatient visit on hospitalization, and finally, severe impairment of exercise capacity. New guidelines present an algorithm of management for patients with advanced heart failure based on Intermax classification, highlighting the need for short-term MCS and then left ventricular assist device or heart transplant when patients are eligible. Also, guidelines provides a table for recommendation for treatment of patients with advanced heart failure. Some recommendations are quite new, while others are changing. For left ventricular assist device, for both destination therapy and bridge to transplant, we assisted to increase the class and level of indication, and this is due to new clinical trials, Momentum 3 and Endurance trials, who demonstrated additional clinical benefit beyond very old rematch trial. Also, new guidelines presented characteristics of patients potentially eligible for left ventricular assist device, and these are persistent of severe symptoms, very severe cardiac dysfunction, but without severe right ventricular dysfunction, low ejection fraction, more than 3, heart failure hospitalization, dependence of IV inotropic support or MCC, or progressive end organ dysfunction. Compared to previous guidelines where heart transplant had no class or level of recommendation, current guidelines gives one C indication for heart transplant and simply states advanced heart failure with no other therapeutic option except for LVADs or heart transplant. However, this type of management presented in the guidelines with left ventricular assist device heart transplant fits only facilities and expertise seen in advanced heart failure center. And for the first time, the new guidelines consider organizational issue for patient referral to advanced heart failure centers based on network between hub and spoke centers. And furthermore, new guidelines consider criteria for referral to an advanced heart failure center to answer two simple questions, when and why, and the algorithm sounds very nice, I need help. These criteria should be based on indication and eligibility, and for patients ineligible for heart transplant or left ventricular assist device, end-of-life care should be considered. For acute heart failure, over the time, heart failure guidelines presented several definitions, all having in common rapid onset, life-threatening, urgent, and hospital admission. However, worsening signs and symptoms may be also gradual, not only rapid, as very commonly seen in patients with progressive fluid overload. Very, very important. Acute heart failure is a multi-event disease, and patients presenting with acute heart failure may have a comparable risk to die irrespective of medical decision to hospitalize or to admit in the emergency department to give IV furosemide. Finally, therapies including now IV treatments and intervention. And finally, the definition incorporates all this changing, rapid or gradual, severe enough for patient to seek medical attention, unplanned hospital admission or AD visit, IV therapies and procedure. Also, guidelines provides a diagnostic workup based on identification, signs and symptoms of congestion, cardiac examination, and for the first time with time to assessment and diagnostic value. And finally, when diagnosis is uncertain, natriuretic peptide measurements. Acute heart failure classification is based on severity at clinical presentation, and this type of classification considers a 4 clinical profile: acutely decompensated heart failure, acute pulmonary edema, right ventricular failure, and cardiogenic shock. Although with a lot of overlappings among this clinical profile, this type of classification scheme provides and facilitates early decision-making regarding appropriate triage and target treatment in high-risk patients. For initial management, this is quite similar to that presented in 2016, highlighting the issue that diagnosis and treatment should evolve in parallel. Only difference is related to life-threatening etiology, and acronym it sounds now CHAMPIT, adding I from infection and T from tamponade, distinct to previous CHAMP algorithm. For AHF management, this is based on clinical profile And this type of subclassification offers therapeutic ramification for any patients with acute heart failure. For congestion, IV diuretics remains as 1C indication. An algorithm of decongestion, it's similar to that presented in HFA position statement with diuretics. For the first time, diuretic response is defined in the new guidelines based on urine sodium content and urinary output. For vasodilators, we assisted to a decrease in class of indication, and this is due to two new clinical trials, Galactic HF and Elizabeth trials, both trials showing no benefit from early sustained vasodilation. For vasoconstrictors, vasoconstrictors' level of indication is remaining the same, but epinephrine disappeared from table of inotrope, and this was because of OPTIMA-CC trial showing a higher rate of refractory cardiogenic shock in patients treated with epinephrine compared to norepinephrine. For morphine, the class of indication is decreasing because of three propensity matching score analysis showing that morphine is associated to short and long-term mortality. For cardiogenic shock, the new guidelines present a new definition. Low blood pressure is not anymore part of definition because we are assuming that hypoperfusion may exist with preserved blood pressure. Classification is based on SKY classification from A to C, A pre-shock, E in extremis, and management consider underlying cause as crucial and treatment of hypoperfusion. Also, new guidelines consider pre-discharge phase as an opportunity to improve long-term prognosis and recommends that patient discharge with acute heart failure, congestion relief to be highlighted. Evidence oral medical therapy should be initiated before discharge, an early follow-up visit, and ferric carboxymaltose in patients with iron deficiency in order to improve quality of life, symptoms, and to reduce hospitalizations. Thank you so much.
Thank you, Ovidio, and it's now my pleasure to give the speech to Colin, Professor Bagent, to introduce the discussion.
Well, I'd first of all like to thank all the presenters, the faculty, for their excellent presentations. But I'd also like to remind everybody just how much work this has been for the task force. Has worked very, very hard over 2 years to produce these really excellent new recommendations. I think the most appropriate thing now would be for me to hand back to the chairs who are practicing cardiologists, unlike me, to explore with our discussants the implications of these new guidelines. So over to you, Marco and Teresa.
Thank you, Colin. So I'm going to first of all give the floor to Fayaz to give us your take on the guideline and maybe start to quiz, and then I'll hand over to Johan Barsaks.
Yes, thank you for the invitation. These are guidelines really outstanding, and there are many new topics here, and we'll have long time to discuss. But the main observation here is that I was talking this morning with the other guidelines committee, and that the ESC, it seems that the ESC guidelines are most based on randomized clinical trials, but on average, only 10 to 15% of recommendation overall in cardiology are based on randomized clinical trials. It's my impression that in heart failure, this average is much higher because the 1A recommendation and further recommendation based on a randomized clinical trial is really exceptionally high, and I would like to praise the trialists and the heart failure specialists of raising this evidence. I'd like your take here, and have you evaluated the number of recommendations which are based on randomized clinical, conclusive randomized clinical trials?
Thank you, Faiz. I'll start with the part of the guideline that I oversaw, which was the chronic heart failure part. And certainly when you look at treatment recommendations for heart failure with reduced ejection fraction, over 92% of our recommendations are based on trials. For heart failure with mildly reduced ejection fraction, of course, we don't have any actually specific randomized controlled trials, but even then we have considered subgroup analyses from HFpEF trials and meta-analysis between HFrEF and HFpEF trials. And even for HFpEF, where we don't have any real concrete recommendations, the reason we don't have is, again, we've considered clinical trial evidence, because the evidence we had to consider up to the end of March 2021, we had no trial which had met its primary endpoint, so we didn't give hard recommendations. So for the chronic bit, it's practically it's over 92%. Yeah. I'll hand over to Marco. Yeah.
With respect to me, it's a very nice question, and actually we have to find a compromise, a balance between evidence from clinical trials and the need to have guidance for treatment. And so starting with acute heart failure, we don't have positive trials. The only class 1A evidence recommendation is for thromboembolic prophylaxis. Then, unfortunately, we had all these negative trials, and we don't have evidence-based recommendations. Advanced heart failure, for the first time, we have a recommendation for heart transplantation, class 1C, because there is no trial regarding transplantation, but it may be so obvious, like the parachute example from flights. For advanced heart failure, for regards mechanical circulatory support, we just have one trial comparing destination therapy with medical treatment, and then we have comparison between different devices. When we move to comorbidities and special conditions, I counted 60% of our recommendations based on randomized clinical trials. So we are again with a very larger proportion of recommendations compared with the other fields of cardiology. Yeah.
I mean, 92% in chronic heart failure is absolutely outstanding. I can't think of any disease or specialty where they have this kind of 90% recommendation based on hard evidence of randomized clinical trials. So congratulations to the heart failure community and the trialist community.
Yeah. Okay.
And we based ourselves on mortality mainly. That's another point, because there is quality of life that's more difficult to evaluate. Yeah.
So, Johan, what are your thoughts?
I can also say thank you very much for your hard work, you both and the task force, and it's an excellent summary of the current evidence. And also in the areas like acute heart failure, where is no real evidence, but there is a very nice help for the clinicians to treat this patient based on expert consensus. So congratulations again, and a lot of work. Perhaps when coming to the details, so I like very much the simplified approach now, the simplified algorithm for drug therapy for heart failure with reduced ejection fraction, and also the inclusion of the SGLT2 inhibitors now here. And these, I call it Fantastic Four drugs now, are to be given in all patients with HFrEF. What about the sequence of treatment? So this is not so clear, I think. Could you comment on this?
Yes, well, I think we've left the door open for clinicians to evaluate the evidence and to make sure these 4 drugs are started, and to tailor how to do it according to the patient, the blood pressure, the renal function, whatever. I mean, in terms of actually interpreting the evidence, of course, the SGLT2 inhibitor trials were done on top of therapy with ACE, ARNI, beta blockers, and MRAs. So some people, no doubt, will choose to follow a sequenced approach, but I think other people will say, I've got to get these 4 drugs started in a timely manner and look at the patient, start the RAS blockade, beta blockade, and then think MRA, SGLT2, and try to do it as quickly as possible based on the phenotype and as safely as possible.
I think it's a very important message for all the people hearing to us, that you should not wait for weeks, months or years until you have the 4 drugs in the patient, but you should do this within weeks and usually. And perhaps a second question in the same direction. So you have specifically given a class 1 indication to empagliflozin and dapagliflozin, but is there not also data there for sotagliflozin in HFrEF?
So first of all, we left it out of the HFrEF indications because those were for all patients being treated with HFrEF, irrespective of their state of diabetes or their diabetic state. But Marco dealt with it in the diabetic section.
When we moved to the recommendations for diabetic patients, we included also sotagliflozin because the trial showing positive results with sotagliflozin was done in diabetic patients hospitalized for acute heart failure. So unfortunately, we just have data regarding diabetic patients, but it's a class 1A indication of these 3 drugs in patients who have diabetes and heart failure.
Yes, I'd like to highlight this unfortunate timing of the guideline, because it's just an hour or 2 before we can hear the full story from Emperor Preserved, which I'm sure will change the guidelines, because at least the headlines news we have heard from the press releases that this trial was positive, right? And therefore, here we have a drug which is effective in reduced and preserved ejection fraction. It happens that actually sacubitril valsartan, at least up to a normal ejection fraction, seem to be effective as well in reduced and also in up to normal ejection fraction. And there are evidence that MRAs, at least spironolactone, from the TopCat reanalysis, that there is a hint that these may be effective on preserved as much as reduced. So therefore, the question is whether we will perpetuate this HFrEF, HFmrEF, HFpEF, and all these acronyms which are ejection fraction centric, whether we will move away sometime and maybe in few hours from now to some definition where drug therapy can be used independent and across the all full spectrum of ejection fraction.
That's very good that you said that. We actually had those discussions in the task force because towards the end of the evidence closure date, we did have, of course, the FDA pronouncement about using sacubitril valsartan in those with below normal ejection fraction, and also the consideration by the FDA of spironolactone in the same group. And so we thought very carefully about changing HFpEF to heart failure with normal ejection fraction. We felt it was a bit premature to do so. Though I would say a small majority of the task force wanted to do that, but not the 75% that's required overwhelmingly to make such a huge change. And then we had, of course, other things to consider. What was the ejection fraction cut point we would call normal? It's a normally distributed variable. There's a high degree of variability around the measurement. And I think we thought we need to wait and see what some of these trials with the SGLT2 inhibitors are going to show in heart failure with preserved ejection fraction. And I think that will be a step. I think that will be a step for the next guideline, completely redefining heart failure. Have I summarized that correctly?
I think, I mean, we have discussed a lot also with the colleagues from United States. And there is one thing we have to remember is that there is an outside world and we have to be clear with the outside world. And so we in the end, preferred to keep this ejection fraction-based classification because somehow still working, and we will see in a few hours how much things have changed. What is clear to me is that there is also there are mechanisms and drugs which are effective in the patients who have an impairment of systolic function, and includes also the patients who have an improvement in ejection fraction, which is a different category from those with preserved ejection fraction. And then there are patients, as Caroline Lamb was pointing out, with hypertrophic cardiomyopathy, with amyloidosis, and we have to look for a diagnosis and personalized treatment, probably more in these patients who have a supernormal ejection fraction.
Yeah, but we have started the ball rolling, I think, with renaming mid-range to heart failure with mildly reduced systolic function, because then now we've created the one category really of a spectrum of HFrEF, where the patients and the drug therapies seem to work much in the same way. And the question then is now, what is heart failure? What is HFpEF or heart failure with normal ejection fraction? And I think that's for the next guidelines to work out.
I'm sure there will be much talk in the next few days about that. And actually, it may create new dynamics in heart failure research, because we were a little obsessed by ejection fraction. And there are other ways to stratify heart failure than only ejection fraction. But I'm being a little ahead of time.
May I ask a question regarding the novel granuloid cyclase stimulator, the very cigarette there? Several cardiologists thought that this may be a 2A indication. Now it's a 2B indication. So often when a drug met its primary endpoint in a large randomized trial, then at the end this is a 2A indication, but you choose a 2B. Could you comment on your discussions?
Okay, so the rules suggest that if a drug has met its primary endpoint, it will get a class 2 indication at level of evidence B with one trial. The nuance then is for the task force to decide, should that be 2A, something that we really should be considering, or 2B, is this something we may consider? And I think we voted on it, but I think the task force considered the magnitude of the effect of vericiguat in terms of it was a 10% reduction in the composite endpoint, with that mainly being due to the reduction in heart failure hospitalizations with no effect on cardiovascular mortality. So we took that into account. And, if you want to compare it with the other one, which has a 2A indication in this category, which is ivabradine from the SHIFT trial, I think you've also got the risk reduction was much higher. It was over 20% in SHIFT. And also we had other analysis from SHIFT in terms of heart rate. There were threshold heart rates where there was a reduction in cardiovascular mortality. So I think the general opinion was to go for something which may be considered, rather than at this moment in time going for should be considered. And on the same, of course, we also had a very similar discussion for omecamtiv mecarbil, with which was a trial with a reduction in the composite endpoint, an 8% reduction, I think, overall. It does not have a class 2B, level B recommendation, because, of course, the drug is not licensed anywhere in the world. And I think, to recommend something in a guideline which people cannot prescribe is premature. But we also did discuss that.
Something about comorbidities. We have talked about diabetes, but certainly chronic kidney disease is probably actually the first comorbidity, most frequent, and which multiplies the risk in heart failure patients. And there have been actually new elements, certainly from HFrEF, and whether it is with sacubitril valsartan and whether it is with empagliflozin and dapagliflozin, that in HFrEF with CKD, there is improvement in renal function as well. So there are cardiovascular and renal benefits. So is this highlighted enough in the recommendation? Because my own take is that heart failure is a cardio-kidney disease, by the way. It's really coexistent and not only comorbidity. It's, very much tied up to the pathophysiology of heart failure. So any highlight on these elements, how where with a single stone you can kill two birds, improve cardiovascular, but improve also renal outcome?
Thank you for the question, Fayez. And anyone taking care of patients with heart failure fights with this chronic kidney disease comorbidity. We have a chapter regarded as maybe too long by some reviewers, but it's long enough, I think, pointing out all these aspects. we have sacubitril/valsartan, which attenuated the decline in renal function compared to enalapril and Paradigm HF, and we have empagliflozin and dapagliflozin, which stabilized the glomerular filtration rate during outcome in the heart failure low ejection fraction trials. And so we really have drugs that can improve the outcome of patients also from the point of view of kidney dysfunction. Unfortunately, and I think this is the major problem, we don't have data, we don't have trials in patients with a really reduced glomerular filtration rate. The lowest level is 20 ml per minute per square meter in Emperor reduced. Then we have 30 in DAPA-HF, 25 in DAPA-CKD. So we really need data, and we don't have data regarding the patients who have a low very low glomerular filtration rate before treatment, and which are about 25-30% of the patients with heart failure overall.
Yeah, they're usually excluded from trials and from all trials, not only heart failure trials, below 20 milliliters per minute eGFR. So there is a clear plea that we develop evidence in this very high unmet need group of patients. Yeah.
Okay.
Can I just comment on that? Because I think, sorry, having said I wouldn't say anything, I now feel moved to comment. Because we should remember that in the trials of SGLT2 inhibitors, patients progressed to below 20, as many of them reached their reached end-stage kidney disease. And so I think we can infer some information about efficacy and safety by looking at different parts of the follow-up of those trials. It's not a complete black hole when it comes to information about those types of patients.
Good.
Thank you.
Yeah.
So I'm going to turn now just for a moment or two to look at what the audience have been sending questions in and what they're on. So the most common question which has come in so far is really about our classification of the role of angiotensin receptor blockers in the new guideline. And I think there are really two aspects to this. One is that obviously an angiotensin receptor blocker, valsartan, is a constituent part of the ARNI. So I think the place of ARBs in heart failure has been downgraded in HFrEF, and it really is for those who are intolerant of an ACE or an ARNI. And therefore, we are left really with the CHARM alternative trial. So we, I think, have correctly given the correct class of recommendation, which is 1 with level of evidence B for 1 trial. And that's really because things have moved on with the ARNI.
Yes, I completely agree. And I think clearly if you do not give an ARNI, which can also be done as initial treatment now, then you give an ACE inhibitor in patients with heart failure, and only at very rare occasions where an ACE inhibitor is not tolerated due to cough or so, and an ARNI is also not tolerated, then you can go for an ARB. But even for the patients with kidney dysfunction, there is no advantage of an ARB.
Yeah. And also to come back, the second most common question is why haven't we given a class 1 indication for starting an ARNI de novo, whereas we've given it a class 1B indication for a switch from an ACE inhibitor? Well, we had a lot of debate about starting ARNI de novo. We considered the PIONEER and the transition data. We voted on it. PIONEER and transition, of course, are not large randomized outcome studies, but nevertheless, they show that it's safe to start an ARNI in patients de novo. The majority of the task force would have gone for that, but we didn't reach the 75% required, and so it has a class 2B level B recommendation. So it's something that may be considered, and it's in the text. So if clinicians choose to do that, remember these are guidelines; these are not commandments, and
I think clearly you can do it. You can start in patients with an ARNI as first-line treatment, but you also have to keep in mind that also in the paradigm study, all patients had to tolerate the highest dose of the enalapril and the sacubitril/valsartan before they were randomized. So in clinical practice, we are still left with patients that at the end do not tolerate the ARNI.
Yeah. So we've left that as maybe considered and not said it is recommended. Yeah.
And it's good that you still kept ARBs, angiotensin receptor blockers, because this is the default option in, unfortunately, many low-income countries may not afford the drug with sacubitril/valsartan, and I know that there are many of them which are this case.
Yeah. So I think there's a question probably best addressed to you, Marco, is starting SGLT2 inhibitors in hospitalized patients.
Okay. Yes, we added a new table of recommendation in current guidelines regarding pre-discharge management of the patients before discharge and immediate in the weeks following discharge after an hospitalization for acute heart failure. And it is written that oral medical treatment for HFrEF should be optimized, initiated, and then, if not done before, up-titrated at 2 weeks after discharge. And also this was debated, and in the end, we just added the generic term of optimal oral medical treatment, which, based on HFrEF section, includes beta blockers, MRAs, ACE inhibitors, or sacubitril/valsartan, and including the switch from ACE inhibitors to sacubitril or the initiation of sacubitril/valsartan before discharge, and SGLT2 inhibitors, which are MPAD, gliflozin or dapagliflozin, or in diabetic patients also sotagliflozin. Of course, we just have the Soloist WHF trial with the initiation during the hospitalization, but also in the outpatient trials, patients were hospitalized, they continued the drugs during hospitalization. So I think there are, and we know that these drugs are effective also early after the hospitalization. So I think there are data to use them as soon as possible.
Maybe I can add, we now have more experience, and also from smaller studies, that you do not harm the patients when you start, when they are sick. For example, even in the COVID study with the dapagliflozin, there was absolutely no harm in these sick patients. So it's safe to start early, and you do not have to be too much careful because of suspected risk of ketoacidosis or so. This is a very rare complication, and we also have good experience when starting in hospital in decompensated patients.
Yes. I'm sure you, as much as me, are concerned about the guidelines being just wishful thinking, because we repeatedly see that these therapies are not being implemented. And we have strategy trials now, and inexorably in all the guidelines, you have the disease management program, which comes out with 1A. But we still have drug therapy not being implemented, inertia. So how we can make the guidelines really forced or implemented? Because from guideline to guideline, we are all just concerned that these guidelines and many more trials, 92% randomized clinical trial-based evidence, but still not being implemented. What to do with that?
Well, we have included at the end of this guideline quality indicators, so benchmarks for the key quality indicators based on the Class 1 recommendations, so that people actually start to audit their clinical results in terms of inpatient or outpatient use. And you have to have a benchmark, and you have to audit your